All right. Alexis, am I okay to start? Yep. Okay. Good morning, everyone. Dr. Kathleen Kieran. I'm here with Dr. Peter Asante as our co-host this morning. This is our last webinar that we'll be co-hosting. It's a very exciting webinar for us. Welcome to our first webinar of the 2025 academic year, and this is our Equitable Care webinar for the Washington chapter of the American Academy of Pediatrics. We're very happy to be hosting Dr. Chase Anderson, who is a friend and a colleague and a wonderful speaker, and I'm just very excited to have them here with us today. Before I turn this over to Chase, I'm just going to give a brief background on the Equitable Care Committee of the Washington chapter, for those of you who are not familiar with our work. This is the committee, or a large chunk of it. We met now, it's a couple of years ago, out in Yakima at Children's Village, and this was our last retreat. And our Equitable Care Committee is comprised of an amazing group of people that care for children within Washington State. They are from diverse backgrounds, from diverse specialties, and provide diverse perspectives on how we can best care for children and what our next steps should be. Many of you are familiar with our toolkit. Our toolkit first came out in 2021 and had 4 different buckets in it. The toolkit is currently being revised and should be available in the next month or so. But the toolkit was prompted by our national reckoning in 2020 about basically the fact that there's an endemic racism in the United States, and really here in Washington State as well. And the toolkit provides actionable ways that anyone who cares for children can take the first steps to provide equitable care and sustain equitable care in their provision of care. As I mentioned, we're going to be updating the toolkit. That link that Alexis, hopefully you can put that in the chat, links to our current toolkit, and we'll link to the revised version as well. These are our contributors. As I mentioned, I just like to show this, but we'll have a different group as well coming through with our next revision.
All right.
Now I'll turn it over to Dr. Asante to do the grand introduction. Thank you.
And before I do that, good morning, everyone. I'm Dr. Asante. I just wanted everyone to know this is not our last webinar ever. It is just the last one that Dr. Kieran and I are hosting.
Absolutely true. We'll still be here, and so should you be.
The girls will still be here, I promise.
Yes.
We do
Yes, but we won't be hosting, so enjoy the show.
And so it is really my privilege to introduce Dr. Chase T.M. Anderson, but you can just call him Chase. And he is currently a child and adolescent psychiatrist at the University of California, San Francisco, the director of the Muses program for Minoritized Youth. I was going to do a Hercules reference, but I'll leave that for you, Dr. Anderson. They graduated from adult psychiatry residency at Mass General Hospital, McLean Hospital, and child and adolescent psychiatry fellowship at UCSF. He completed his undergraduate education in chemistry and their master's in biological engineering at MIT, and is a graduate of the Northwestern Feinberg School of Medicine. Their writing has appeared in NPR, Scientific American, Wondermind, Stat News, the New England Journal of Medicine, and other news and journal outlets. In their free time, Chase enjoys going for long walks, doing gay things, listening to K-pop, reading fantasy books, playing soccer, writing, planning dinners with friends, and dreaming of how we can be better in the world together. And I will turn it over to Dr. Anderson.
Thank you very much for having me, and good morning, everybody. It's really nice to be with all of you. So let's do this. All right, can everybody see this?
Yes.
Okay, perfect, thank you. So in terms of disclosures, I do not have any disclosures. I truly am on an academic salary. So today we'll be talking about minority stress in the medical professionals, so how minority stress affects mental health. This was actually a QI project that was about 5 minutes that a friend and I did during residency that has been expanded since then into a full-blown talk. So sometimes QI projects can launch careers. So just wanted to bring that up. And that's the only time I will ever say that about QI projects. In terms of an overview, part one will be a personal vignette to bring you into what minority stress can do to somebody. Part two will be what is minority stress, so some definitions to bring us all to the table together. Part three is minority stress in America, so some statistics. And then part four will be microaggressions and minority stress. Part five will be how do we help and how do we grow. Part six is how can minoritized people protect themselves. Part seven will be a personal vignette revisited, and then part eight is Q&A. So what I'm going to be talking about is about certain parts of mental health, including depression and suicidality, things that I have lived with. I'm in remission right now. I'm very open in my articles about this, and so I want everybody to feel comfortable asking the questions they want to ask. The other thing is that I know sometimes this can be activating for some people as a discussion point. So whatever you need to do, if that means stepping away for a moment or taking time for yourself, or just having your camera off or like reaching out to me after, please just let me know. I'll stay a few minutes after just to make sure that if anybody needs to process, I'm here with them. In terms of learning objectives, at the end of this presentation, learners will integrate into their practice the ability to specify at least 3 ways in which minority stress affects mental health, assess how minority stress can affect intersectional LGBTQ plus people, and identify at least 3 ways in which we can make environments safer for minoritized individuals. So let's start with that personal vignette. My life changed when I came out at age 12. Until then, overall, I'd lived this idyllic little life, one where I was educationally and economically privileged in ways I didn't even know at the time. I hadn't heard the N-word yet. I knew the world was hard for gay people from newspapers, but didn't fully grasp how things were about to change. Through the next years into high school, I was called the N-word, homophobic slurs, and I went through bullying because of facets of my identity. Even though I was one of the top students, even though from the outside many people thought I lived a perfect little life, even though I made it look good, people didn't know that my smile hid so much. I didn't know what to call it at the time, but I began to develop depression and anxiety. I feared going to school even though I loved learning. In high school, because of discrimination I faced, I had 1 suicide attempt. No one knew I wasn't hospitalized. Then I'd entered college at MIT and my life changed for the better. Not at first, though. Within the first few weeks, I was rejected from a fraternity because I was open about being gay, had to meet with MIT faculty about it, and subsequently failed all my first exams because I developed panic attacks for the first time. I was no longer a stellar student, and I was sure I was going to fail out. This led to my second suicide attempt. Again, no one knew. However, I thought I was going to end up dead. Yet, something different happened. The friends I'd already made at MIT validated my experiences of discrimination, shared their own experiences with discrimination and mental illness, and how they dreamed about changing the world. They bonded more tightly with me, and we learned how to support each other. We saw each other as more than the characteristics often used to define us and shattered those stereotypes. We became a family where we spoke about topics of diversity regularly and shared our lives with each other. Because of them, I made it my purpose to help others not experience the same issues I had. I got to see what it also meant to truly live. It wasn't perfect, and there were still instances of discrimination, but they became more rare as time continued, and there was nearly always someone besides myself who spoke up against such instances. Those friends saved my life. They helped me soar for the first time as I embraced my identity and we celebrated each other's identities. Because of our friendship, without meds or therapy, I entered what was later called the golden years right before grad school at MIT. A 2-year period where I didn't have a single depressive symptom or any suicidality. I thought my depression was gone forever. I left MIT with the certainty that America was ready for a shy yet confident, Black, gay, introverted guy nicknamed Dream and a unicorn phoenix by his friends. Medical school, however, was about to disillusion me and bring back the one thing I thought was cured forever. I became class president in the first few weeks at med school, and things became a slow descent into hell. I was told by a classmate that I probably won class president because I'm Black and gay. I heard about how I talked about being minoritized too much. I started to get shut out and shunned, even from events I helped plan with classmates. 6 months in, my depression, anxiety, and suicidality had returned. Every day became about social navigation, balancing class president, finding allies, including our vice deans, certain deans, and attendings, educating people constantly about the discrimination they were enacting, taking on certain deans who enacted discriminatory behaviors, making changes with others, handling schoolwork, and planning my escape from medical school. All the while, my identity fractured. I began to fail exams. I cried alone in my room at night and woke screaming from nightmares. I couldn't even tell my friends from Boston or family in Seattle what was happening because of the shame I felt and had been made to feel. Because of all of that, I started medications and therapy for the first time. Yet, even with medications, therapy, an abundance of friends in medical school, and alliances built, that didn't stop the flood of constant discrimination that continued to break me. I failed 4 shelf exams in a row. I had never felt and been made to feel more alone. This led to one night in third year where I had plans and intent to suicide. After that night, there were several breakthroughs, including being more open with my friends from Boston about how bad medical school was and my family in Seattle, and I honored my surgery shelf and taught myself further tools to face down discrimination. But I felt like a shell of the person who once dreamed of more. Although my psychiatrist therapist and I agree I'd entered clinical remission in my 4th year, my symptoms flared whenever I experienced discrimination. I couldn't figure out why my depression didn't fit the classic criteria we use in psychiatry, but that clinical remission was enough to hold me steady. I then matched back in Boston at a university where the program director said during interviews that she hadn't heard about issues around being Black, but if there were issues, I'd be supported. I raced back to my friends in Boston, hoping to feel truly safe again. In residency, I saw the descent into chaos coming a bit better this time. For my psychiatry rotations for the first 3 months, I was told I was above where I needed to be. I thought I had found safety. Even when an attending who was also minoritized warned me that appearing to be confident and competent as a Black gay male would lead to discrimination and backlash, I thought that couldn't be true. Then, on my internal medicine rotation, I had an attending who kept pimping me in front of colleagues in a way that caused my panic attacks to flare. When I told her this, her pimping worsened. I heard how she'd done the same to other trainees. In the hospital, I was being called the name of the only other Black psychiatry resident who looked nothing like me, asked if I was there as transport. My knowledge and the knowledge of other minoritized people was constantly questioned, and I was disparaged by some patients and staff and attendings and saw the same happen to colleagues. 1 week later found me standing at the sink in the hospital bathroom, crying before rounds, suicidal, having to force myself to go to work and not run away. On her evaluation, the attending said I was unprofessional, was worried about my being a danger to patients, and that my knowledge was far below my peers. Although other evaluations said I was beyond where I needed to be and praised my professionalism, my program directors labeled me as unprofessional, rated my knowledge and professionalism below my peers, and I was ignored and told I was the problem when I told one of them what was happening in the hospital. I had to do a pseudo remediation with the internal medicine chief resident mornings after working overnights, where senior residents said I excelled. Faculty had supposedly secret meetings about my not wearing a tie. I'd rarely felt more stupid or embarrassed or that I was the problem. My suicidality worsened in frequency and intensity. Because of so many lived experiences, however, I knew what to do to survive this time. With my residency class, we strategized how to handle program leadership and make changes. Then we went to war with our program when we deserved peace and a safe training environment. I set aside the guy who simply wanted to date another guy and have a calm life in order to mentor others, push where I could with faculty, and support my colleagues. We led with vulnerability and used it as power as we spoke up constantly when we all wanted to sit in quiet peace and dream upon the stars. This time around, I was more open with my friends from Boston and also family in real time about what was happening, even as I had less time with them because I didn't have the energy. My colleagues set aside many of their dreams as we spoke up constantly and consistently. I restarted my antidepressant, which I had been able to come off of after leaving medical school. I also started therapy again. I wasn't just scared this time that I was going to lose my life. I was constantly terrified as I watched my spirit fade. 1 year later, soon after one morning where my suicidal thoughts became more intense with intent, and I went on to have an attending tell me my work was excellent that day. The same program director who hadn't listened to me when I told her how bad things were was crying as she apologized to me for how she hadn't listened, how she had put me in a horrible position, for how she and the program had hurt myself and others. She and I then got to work. Every week, we'd meet to discuss aspects of her identity, the program, certain instances of discrimination I had experienced or classmates experienced. This was all on top of working to be the model minoritized physician. That didn't stop the depression. It didn't stop the daily discrimination I saw or experienced, but it did help to have a leader who validated myself and others, who worked to better things. At the same time, I was planning my escape from the program. I also began to speak out about experiences under a pseudonym on Twitter because I wanted people to not have to feel so alone. When the co-program director, who was now an ally, announced she was going to another program, that solidified my decision to fast track. During interviews, I had better questions this time around because for minoritized applicants, it's not simply, oh, this is a great program. It is about where will I be safe? Where will I experience the least discrimination? Faculty at UCSF were the most honest. I matched at UCSF. Then George Floyd was murdered, and people who had enacted discriminatory behaviors were rushing to apologize, invaded my space when I wanted to be left alone. Our program even said how they had hurt people, but never specifically apologized to anyone, and discrimination continued. Our class forgave in some ways because I saw it as people having blind spots and enacting learned behaviors from society. But that didn't stop the knowledge that the rush to assuage their guilt and these delayed apologies didn't heal my shattered heart or give me back the lost time, dreams, peace, or sense of self. So I geared up to leave with plans to leave academia. Fellowship was more of the same. Began saying goodbye to my oldest friends and newer friends and mentors, wishing the program had been safe enough for me to stay with my friends in Boston who I'd promised to be together forever with. So what does that mean for minority stress, and what is minority stress? The typical definition is the process through which stigma directed towards sexual minorities influences health outcomes. This term came into being in 2003 by Dr. Elon Meyer, who was studying LGBTQ plus populations. And so what was noted at the time was people had this thinking that people who were like LGBTQ plus or racially minoritized were just born more predisposed to having depression and anxiety. He went and proved that that's not true, or was part of proving that, and that what happens is that people experience this minority stress, which leads to mental health outcomes. He also had done a paper on this earlier, so before 2003, but then it didn't go anywhere. And so he held on to the idea and then republished it. So basically, just remember that anything you do, you can bring up 5 years later and people will be like, this is amazing. So, however, the definition is actually broader than that because a lot of other minoritized groups noticed that this was happening to them as well. So out of this comes the minority stress theory. Individuals from oppressed social groups experience excess stress and negative life events because of their non-dominant status or statuses, which can lead to or exacerbate mental health problems. These effects are unique, socioculturally based, and long-lasting, which means they're additive. The way I describe it to the kids that I work with is think about getting a paper cut. You get one at the beginning of the day and you're like, that's annoying, but I can fix it, or I can like put a Band-Aid on it. Now imagine getting 1,000 paper cuts per day. And those are things like hearing the N-word, or people not looking at you, or people ignoring you, or people saying that like Black people are not as smart. So eventually those things lead to 1,000 paper cuts per day, or it's also called death by 1,000 cuts. And so you don't know where like the wounds are going to come from or where the like injuries will come from either. The other way I describe it to people is I like to watch Sailor Moon, and because it's an amazing show. And so I think she has this thing called the silver crystal, and it basically encapsulates all of her shine and who she is. Now imagine getting a crack in part of that shine. It starts leaking light, and that's your sense of self leaking out a little bit. You can patch that up though, or it'll heal. Now imagine getting 1,000 cracks per day. Eventually your shine shatters and you don't know who you are anymore. So that's what happens to people experiencing minority stress. Along with this comes institutional discrimination. So these are disparities that systematically favor certain groups. This includes housing. In the 30s, there was this thing called redlining in Chicago. It still happens in America today, even in SF or other places, where certain people's houses, especially African Americans, were appraised at different rates, and they were not allowed to buy homes outside of certain areas. This also applies to schooling, employment, health, and justice. So this is the like graphic for minority stress. So what I want to draw your eye to first is this is for transgender people. And on the left are these things called distal stressors. I want you to think of these as outside stressors that then impact somebody. So these are things include gender-related discrimination for difficulty getting appropriate healthcare because of gender identity. There's also gender-related rejection, so rejection by family members for being transgender. Gender-related victimization, so being physically or verbally harassed. There's also non-affirmation, so even respecting somebody's pronouns has been shown to actually help with suicide attempts and to help somebody feel seen and validated and reduce depression and anxiety. So all of these outside stressors can lead to outcomes such as worsened depression and anxiety and suicidal ideation, along with substance use. However, what can also happen at the same time is that those outside stressors can become internalized. So even though somebody who's transgender might know, oh, people in America are messy in some ways and have messy actions that are actually hurting me, this is them, it's not me. Eventually, what happens is this chips away at them, like that minority stress fracturing that I talked about. And those become then proximal stressors. So these are internalized things that somebody then starts to feel about themselves. So this can include internalized transphobia, so feeling embarrassed by one's gender identity or being transgender, and enacting that towards other transgender people sometimes too. Negative expectations. So even if you meet somebody who is very accepting of somebody being transgender, if you have gone through minority stress, then what can happen is you actually expect that they will react poorly to you being transgender. There's also non-disclosure, so somebody feeling as though they do not want to talk about their identity because it's led to backlash or they've not been supported effectively. So that can also lead to the outcomes that I talked about with worsened mental health. However, what can block minority stress and why I start with that personal vignette are these things called resilience factors. I, with the kids, call them strength-based factors because resilience factors can sometimes be blaming or shaming of the person, saying like, you need to be more resilient. So what comes along with the resilience factors or strengths-based factors are this thing called pride. So feeling unique in one's gender identity. So for myself, that was at MIT feeling pride in being Black and being gay. And that was something I hadn't felt since I had come out. So that actually helped with reducing my suicidality and actually helping me reach those years where I didn't have any. Also, there's community connectedness. So this does not necessarily mean only transgender people spending time with transgender people. It can also mean just a community that is supportive. That is also why I show that personal vignette to show that my friend group was very diverse and the fact that we simply were there for each other was life-saving. So how does minority stress play out in America? So in terms of racial statistics, a study by Randy T. Lee looked at major lifetime discrimination. They noted that 48.9% of African Americans versus 30.9% of white Americans had experienced lifetime discrimination. The reason it's so high for white people is that women were included in that category as well. In terms of day-to-day discrimination, 44.4% of white people said that they had never experienced day discrimination. Only 8.8% of African Americans were allowed to or able to say the same. This also plays out sadly in terms of pay discrepancy. So they looked at people who came in at the same educational level, at the same like entry level, and were doing the same amount of work. And they noted that some people were not promoted. And they also noted that they were passed over for promotions in general, as well as for pay opportunities. So this played out for 57% of African Americans, 32% of Hispanic Americans, 31% of Native Americans, 25% of Asian Americans versus 13% of white people. The slide is a little bit busy, but I want to draw your eye to the right-hand column, yes, regularly. So that's yes, regularly having experienced discrimination. For white people, it was noted to be 3.82%. For every racially minoritized group, it's higher. So for Black people, it was 11.23%. For Asian Americans, it's 10.85%, and so on and so forth. In terms of some statistics for LGBTQ plus Americans, so for youths identifying as LGBTQ plus, there's a study that is done every 2 years. And so what they do is they look at different high schools across the country and they look at how accepted they feel, bullying that they've gone through, how they accepted they are at school and at home, how supported they feel. So for youths identifying as LGBTQ plus, they noted that all sexually minoritized adolescents reported higher rates of violence victimization. This included feeling unsafe, being forced to have sexual intercourse, being threatened with a weapon, being bullied at school or online. In terms of an example, for being bullied at school for gay males, they noted that gay males said 27.7% of gay males had experienced bullying, 14.6% of heterosexual males had. So that's almost double the rate. Lesbians also reported higher use of cigarettes and marijuana. And then the prevalence of cocaine, heroin, methamphetamines, ecstasy, and inhalants were higher in all sexual minority groups. So one of the things to take a step back and think about is that when somebody comes in and says they're using substances, one of the most important questions we can ask, and this is why I love psychiatry, is why? Why is that person using substances? What happens usually is that when somebody's going through minority stress, they have not been taught or provided the coping skills necessary to not only understand what's going on to them, but also to know like how to deal with it. And so that leads to higher rates of substance use in order to cope and not be present or to like get outside of their body because they're in so much pain. So how do we humanize people who are using substances is something to think about. This also sadly plays out in the prevalence of suicide attempts. So the numbers on the right will be slightly different because they were looking at different high schools. So lesbian and gay people had a prevalence of suicide attempts at 24.3% versus for heterosexual people, it was 13.1%. For bisexual people, it's 28.3% versus 23.2%. And the statistics actually reverse for people who said they were unsure. So it was 12.4% versus 14.9%. The reason that it reverses is that people who say they were unsure sometimes were not displaying stereotypically gay traits or were not out, which then led them to not be as predisposed to discrimination. In terms of drawbacks of this study, they saw high dropout rates, and they actually think they're underestimating the rates and prevalence. The reason that this underestimation occurs is that gay people and LGBTQ plus people in general form their identities for their sexual orientation actually earlier than their heterosexual counterparts usually. That actually exposes them to more discrimination at an earlier age. So some of these people did not make it to the study either because they dropped out of high school or they dropped out of middle school or even earlier, or they actually suicided by that time. And since the 2016 election, things have sadly only gotten worse. And so the reason for that is that the people we elect as politicians are actually very important. So people are experiencing constant minority stress as of right now because of just hearing about anti-trans bills and things like that. The Trevor Project did a 2024 survey and that looked at LGBTQ plus people aged 13 to 24. They noted that 49% of people aged 13 to 17 experienced bullying in the past year. 23% had been physically threatened or harmed, and 60% felt that they had been discriminated against because of their sexual orientation. 90%, so that's really extremely high, said that their well-being was negatively impacted due to recent political events. And 39% of young people seriously considered attempting suicide in the past year. That is consistently higher than their heterosexual counterparts. 84% said they also wanted mental health care, and 50% of those said that they were unable to get it. So even accessing care is very important and very hard for minoritized individuals. In terms of statistics for Asian American sexual minorities, previous studies I have been talking about demonstrate poor mental health, but those were predominantly in white LGBTQ plus samples. So research demonstrated that external racial stressors among Asian American sexually minoritized individuals resulted in greater psychological distress. A study done at the University of Tennessee noted that Asian American LGBTQ plus persons experience rejection, prejudice, and discrimination from the overall LGBTQ plus community. So just because somebody is part of the LGBTQ plus community doesn't mean that they don't have other facets that might be discriminated against. So thinking about how our different cultures and how different facets of identity all play together and also clash sometimes. They noted increased internalized heterosexism or internalized homophobia because of violating traditional Asian values such as harmony and complementarity. And among 314 LGBTQ plus people of color studied, 58 of whom were Asian American, they saw higher rates of depression, perceived stress, and need for acceptance. They also saw this thing called ethnosexual mythology. So this is fetishizing by a different name. So reducing somebody to their skin color because of just like not being seen as an actual person. So the example that I give for this is when I was in Chicago and in med school there, and then also when I was back in Boston and like on dating apps, people would open their messages to me with like, I love your black skin, or I love how black people smell, and things like that. So those are the things that people go through on a daily basis, just trying to interact in their cultures and things like that. So how do microaggressions and minority stress happen? So just to bring us all into some definitions together, microaggressions are broadly defined as behaviors that ambiguously disempower racial minorities. That's actually an umbrella term, and there are three separate categories underneath that umbrella term. The first is microassault, so explicit acts of racism, saying someone is of lesser worth. The next is micro-insult, saying someone didn't earn their position. And the last is micro-invalidation, saying that we are all the same. Along with this comes a pretty cool term, but it actually is kind of a horrible thing. known as institutional betrayal. So this is normalization of bad behavior. So the example is that if a medical student starts a rotation and goes to an attending and then experiences discrimination, and then they go to the dean to report it, how that dean responds will actually portend how the mental health of that medical student will go. If the dean takes that attending off of service or has them apologize, that medical student's mental health will actually end up being better. However, if that dean does not protect that medical student or says that the medical student was the problem, that actually leads to worsening depression and anxiety. So how we react in situations in academic centers is also very important in how we protect trainees. Along with this comes the need to talk about intersectionality. So this is the interconnected nature of social categorization such as race, class, and gender, which create overlapping and interdependent systems of discrimination and disadvantage or advantages. So I sit before you as African American and queer, and because I'm African American, when I walk by police people, I get nervous sometimes. And so what I started doing when I was younger was I actually would pitch my voice to be higher, and I'd done that for years. I actually forgot that I was doing it sometimes. And then I also will walk in a more stereotypically gay manner and have different gay mannerisms that I use. So sometimes people can use different facets of their identity to shield other aspects that might be targeted. Along with this comes the intersectionality paradox. So the thinking was that if African Americans had higher socioeconomic standing, maybe that was the only thing they needed in order to like do better. They've done studies on this and it does not play out. So they looked at African American women who had higher socioeconomic standing and compared their mental health to that of white women at the same standing. They noted that the African American women still had worsened mental health, and that is because of racism and discrimination. Along with this comes the multiple jeopardy perspective. So none of you need to memorize anything that I'm sharing. This is just to build awareness. So no pressure in any way. The multiple jeopardy perspective is also known as the multiple disadvantages approach, and it's also known as the multiple hierarchy stratification. I don't like this version, but I just want you all to be aware of it. So is assigning high and low status traits for different facets of identity. The example is an Asian American bisexual female in America would be assigned 3 hits for low status traits, whereas a white heterosexual male would be assumed to be the jackpot in America and would be assigned 3 high status traits. However, just because somebody is a white heterosexual male does not mean that they have not gone through discrimination in other ways. So there's always a need, and this is again why I love psychiatry, to take a step back and ask a person, how did they get to be who they are? And to recognize that just because they have certain advantages and privileges does not mean that they don't have other disadvantages. So I'm going to share some things that people who are of different racial groups and different ethnic groups and different groups in general actually can experience on a day-to-day basis. For Indigenous people, so sometimes hearing things like, what is your totem animal or spirit animal? You speak English so well. My grandmother was a Cherokee princess. I am ex-tense Native American and things of that nature. We're not going to go through all of them because you just know that there's a lot more that could go on for people. For LGBTQ plus people, assuming that one partner is the man, the other is a woman, referring to LGBTQ plus people as a lifestyle choice or just a choice in general, telling someone that they don't look non-binary, expecting that gay people have certain personality types or interests based on stereotypes, asking a lesbian how they have sex or derogatory comments about gay sex in general. These are things that people go through on a daily basis, and it goes back to the death by 1,000 cuts that I was talking about earlier. For Latinx people, comments about being too loud and also making fun of somebody or questioning their pronunciation, asking if somebody's family is back in Mexico, telling someone who is Latinx to speak in English. For disabled people, oh, I can't believe that you're married. Come on now, we all have some disability. You people are so inspiring. Not making eye contact with someone just with a disability. Something that I even saw as an example was I'd never date someone who uses a wheelchair. So just thinking about how the words that we use can really impact somebody's mental health. So how does this play out regarding residents? So we're going to bring it back to training a little bit. And also patients. So we're starting with patients, then we'll go to residents. In 2017, Fitzgerald looked at vignettes to examine the influence of patient characteristics on attitudes, diagnoses, and treatment decisions. They noted that nearly all, so 35 out of the 42 articles, found evidence of implicit bias. This was bias around race, age, socioeconomic standing, mental illness, weight, having AIDS, patients who've experienced brain injuries, people who use intravenous substances, disability, circumstance that is social in nature, and gender. They actually saw the same levels of implicit bias as the wider population. So if you took the hospital or if you took America and shrunk it down to a hospital size, you'd actually see the same rates of discrimination playing out. And when physicians were less certain of coronary artery disease diagnoses for middle-aged women, they were more likely to give those women mental health diagnoses compared to men. And actually, they noted that intersectionality can play a large role in protection, like I talked about earlier. How does this play out regarding residents? So Lisi in 2016 looked at bullying. So these are repeated acts or practices directed at one or more workers, unwanted by the victim, done deliberately or unconsciously, but clearly cause offense, humiliation, and distress, and may interfere with job performance and or cause unpleasant working environments. Examples that they saw were unjustified criticism, humiliation in front of colleagues, intimidatory use of discipline or competence procedures, undermining personal integrity, and shifting goalposts. Shifting goalposts, the example that I'll give is that if a medical student comes to an attending at the day of like the start of a rotation and says, "What do I need to do to achieve honors?" That attending says you need to do A, B, and C. Med student does A, B, and C. Then the attending will say you need to do D, E, and F. Med student does A, B, C, D, E, and F. Then the attending will say you need to also do X, Y, and Z. So what they're doing is moving the goal line so that med student will never achieve honors. 69.8% of residents in the US had experienced workplace abuse, and the most common form of abuse was verbal in nature. In terms of themes that they saw in mistreatment, they saw a lot of hierarchy. So that's why I tell people to call me Chase. I tell staff and patients that too. We can't completely get rid of the hierarchy. However, we can flatten it a little bit. They also saw silence, incognizance, fear. So 79% said they were afraid to report. There was also a lot of acceptance and denial, or what happened to me wasn't that bad, or everybody goes through this. They also saw a legacy of abuse. So if a med student goes through abuse, they are then more likely to become an attending who actually abuses other trainees as well. So how do we break that cycle is important to think about. Lisi also saw that there was a sequelae of resident mistreatment that plays out on the individual and systemic levels. There's a cost to the system with higher rates of medical errors, harm to patients, and dissolution of care. 67% who witnessed disruptive behavior felt it contributed to adverse events. There's also a cost to the individual. They saw higher burnout rates, thoughts of desertion, depression, PTSD. So actually like having nightmares and things of that nature and being hyper aware, hyper vigilant, and also higher rates of substance use and suicidal ideation. 20% said that they would not pursue medicine again, and several would advise others not to pursue. So unsurprisingly, this is worse for minoritized trainees. So Justin Bullock, who does really beautiful articles about his own mental health and living with bipolar disorder and also medical training in general, looked at minoritized fourth-year medical students and noticed that they experience this thing called stereotype threat. So when I talk about minority stress, that is outside factors becoming internal. Stereotype threat, think about that as an internal process that then affects how you react and work in the world. They also looked at supervisor biases as well as possible prior poor academic training. And so they noted that stereotype threat can be triggered by standing out or even seen to be standing out. So when I go into a room, I think about how many other African American people are there. And so I'm already assessing what is happening in my situation and environment. They also saw reliving of past experiences. So even if somebody has a great experience with a couple people, if they've had negative prior experiences, they're more on guard for those negative experiences to happen again. And even witnessing somebody else going through microaggressions can lead to by proxy trauma. They also noted that non-white students receive less favorable med student performance evaluations and lower clerkship grades, even when doing the same amount of work and actually excelling in some ways. So part 5, how do we help and how do we grow? The first thing we do is we ask. So when Mark and I first did this presentation, the 5-minute one, we were like, oh yeah, you can just ask minoritized people how things should be changed. And then later on, as I started doing this talk across the country, I was like, oh, I don't want to be asked sometimes. So it is important to always give people an out. And the way I do that with the kids that I work with is when I first meet them, I ask about facets of their identity, including sexual orientation, and it's part of my standard intake, as well as pronouns, as well as different like facets of identity. And then later on in the conversation, I will say, because you identified as an Asian American, bisexual, and a person in America, we know that America can be messy. And the kids usually laugh when I say that. And then I will say, because of that, you may have gone through experiences of discrimination because of facets of your identity that only apply to those facets of your identity. Has that happened to you? And I want you to pause before you answer, and you don't have to tell me everything because I know this is a sensitive topic. And if you are not ready, you can say that you want to talk about it later, but know that I am a space for that to be discussed. And the clinic I run, we actually set that tone early by saying it's a clinic that we talk about these things as well. So that gives the person an out. So if they do not feel ready to talk about it, that actually is very beneficial to them to have that out. An example I'll give for this is one of the kids I worked with in fellowship, who I still am working with, who's now a young adult. When I first met, we brought up these issues and he said he wasn't ready. 2 years later, he came back and said, I remember when you first asked about this, and now I'm ready to talk about it. And his depression scales have continually gone down as he like figures out himself. And he comes in and he says, oh, I had these external stressors that like were causing these things where I'm using substances for that night because of this. And like it's from my history of trauma. So even his verbiage has drastically changed. And it's very cool to see. We also grow by educating ourselves and protecting minoritized people. There's also a danger of false allies. So people saying they are allies, but then actually doing the opposite reaction. So how do we change that paradigm as well? We also need to come at this from humility and seeking to understand and truly converse. We're all going to make mistakes as we do this. I still make mistakes when I talk about these things. So it is, how do we recognize those mistakes and be accepting and apologize when we do make them? We also need to believe minoritized people when they bring issues forward, and we ask, but again, with that caveat. So one thing that also comes up for people in medicine is they think that they aren't supposed to talk about this, or they feel ill-equipped, or is this actually going to make things worse? So talking about discrimination and talking about somebody's facets of identity are actually some of the most life-saving things we can do, and it should be done even if we stumble sometimes. So I will show a study that is to this effect. So in 2007, Constantine looked at the impact of racial microaggressions on the mental health treatment of African Americans. They looked at white therapists and how they related to African American college students. And although African Americans comprise about 13% of the US population, they're underrepresented in mental health care settings. What were cited in reasons in the study were economic constraints, service access barriers, inflexible work schedules, and lack of knowledge of resources, and cultural mistrust. So what you'll notice in all those reasons is that racism is underlying them. They also overall looked at racial microaggressions in counseling by white therapists, the Therapeutic Working Alliance, counselors' general and multicultural competence, and satisfaction overall with counseling. What they noted that was that colorblind attitudes are not actually talking about racism or talking about discrimination or facets of identity, led to lower levels of empathy and blaming, while also people felt as though the provider was missing like actual factors that led to their mental health being worse. They also cited that African American patients became frustrated when counselors avoided topics of race and racism. And they looked at different microaggressions, including things like color blindness. So saying, I don't see color, everybody is the same. Everybody is different, as we talked about. Over identification. Oh, because you went through this one thing, I've gone through something similar, when it's a totally different experience. Stereotypic assumptions, also accused hypersensitivity. There's also looked at the meritocracy myth. So this is a thing where saying like, oh, this group of people works hard, and so they're doing well in America. It actually, what that happens within that like paradigm is that actually segregates different minoritized groups, and so they actually fight against each other. So that is a myth, because none of those minoritized groups will ever actually be able to fit in completely with white society in the way it is. In terms of overall findings, they saw that unconscious and conscious racial hostility had undue effects on Therapeutic Working Alliance. I'm surprised, like, that's not shocking to anybody here, probably. They also know that the perception versus intent were very important. So it is important when talking about these things, asking how something landed for somebody, because they may have received your comment totally different than what you intended. They also actually noted that unconscious and subtle racial microaggressions have an even more profound negative impact on mental health. So the thinking sometimes was that, oh, like being called the N-word is actually like more dangerous than the subtle things. What has been noted is that the subtle moments are saying like, oh, I wonder if that person got this position because of this, actually is more damaging to people because it sits with them longer. So again, how do we heal? So Lisi, this article by Lisi is one of the coolest articles I've ever read. They saw that education and awareness, just in and of itself, so all of you coming to this talk, builds awareness and leads to decreased bullying. They know that good leadership led to prevention and protection and defined better culture. They also saw inner community support led to better mentoring overall and fostering of community and a more supportive community. They also saw the need for confidential mental health services in academic centers. So why is there not an opt-out version where like you come in and are assigned a therapist or psychiatrist so you don't have to scramble to find one if you do need somebody? They also saw the need for feedback standardization and safe mechanisms for reporting, and in worst case scenarios, building exit strategies. So how does somebody get from one university to another academic center if that academic center that they're at is actually too dangerous for them to exist as themselves? We also need to recognize, name, and understand these attitudes and actions, identify our own implicit biases, and also do diversity training that is not only about diversity now, but we need to talk about the history of like how academic centers have hurt minoritized people, and then that will help us with figuring out how do we move forward. We also need continued research that address patients' social risk factors and needs. So a lot of talks don't talk about how minoritized people can protect themselves. And so that's why I added that to this talk, because a lot of times it'll say like, oh, this is what racism is like, and it's very much built for white people. And so we wanted to add something a little different. Thank the gods, Beyonce, there are actually techniques and strategies to protect oneself that prove promising. So they saw that reflective coping, so actually being able to process and talk about the event and say, I went through this, and then having problem-solving activities of how to deal with it in the future. They saw in 134 studies about discrimination health outcomes that this was beneficial. This also included cognitive restructuring, expression of emotion, and social support seeking. So going back to that vignette, me having all of those friends where we could process things, we were basically group therapizing each other, was very supportive and actually was part of why my suicidality vanished for those years. They also saw the importance of community and central identity. Central identity is pride, by another term. They also noted other factors such as social support, spirituality or religion, using humor, role shifting, so figuring out like how to adapt into certain societies, armoring, cognitive reinterpretation, and withdrawing and things like that were actually beneficial too. No, Chase, we need some specifics. So the American Psychological Association actually made an article called Disarming Racial Microaggressions. They noted that there are different techniques that prove to be beneficial, and they saw this across like hundreds of studies. So making the invisible visible is one of them. So calling attention to what you just noticed and keeping it to the facts of that moment. Disarming the microaggression by saying, I don't agree with what you just said. Educating the offender is also one. The thing that I always say with the kids when I start teaching them this or other people is, or in talking to medical students too, is some of these techniques are dangerous in certain situations. So they have to be practiced beforehand, because what can happen during microaggressions is that people freeze. That happens to bystanders. That also happens to the person experiencing discrimination. So practicing beforehand and knowing which technique to use and what will be safe with certain people and certain groups is very important as well. They also saw seeking external validate or intervention, as well as setting clear limits and redirecting and reframing were helpful as well. These are the steps written out. It's a little bit more like it's a tiny slide. So I just wanted to draw your attention to the fact that like people made a slide and like made a whole diagram around this. So how did that vignette that we began with end? I flew to San Francisco and cried in my apartment from missing my friends, relief that I escaped an unsafe environment, and over the loss of my once dream to stay in Boston forever with my friends. Over the next weeks, I took time to myself to reflect, to look to the future. A few weeks later, I revealed my true identity on Twitter because I felt safer, and then I began my fellowship. Within weeks of my arrival, my depression and suicidality vanished, and I entered the third remission period in my life. I've had a total of 6 major depressive episodes with suicidality over my life. The last one was, I would say, ended in March, and so I've been in remission for the past 4 months. And actually, I've taught myself even more tools where, like, even when certain parts of depression start happening, I'm able to navigate them better. I say that to all of you to say, like, things can get better in terms of mental health, especially as we teach ourselves and as we like get the help that we need. I found a program where my program director said to me, "You never have to take on issues with racism if you don't want to. It is not your job to handle these things," and back that up with words and action. I got to work with co-fellows who spoke up around instances of discrimination before I had to say a word. I had the opportunity to work with mentors who looked like me, who focused on what really matters, helping kids, their families, and our world. After 7 years, I finally found overall safety and broad support in academia. Because of that, so this is about 4 years ago now, I began to fully live again. I got to again more fully become that unicorn phoenix nicknamed Dream by his friends years ago. I'm different, but similar in the important ways to me. I've had time to work on articles around minority stress, do lectures at other universities like this one, engage around topics of diversity by choice and not for survival, skip down the street listening to K-pop, go queer clubbing, sit and simply breathe, and build a family here with old friends and new, and be fully present when I see old friends and family in Boston and Seattle. I've been able to see just how far someone can fly when not constantly barraged by discrimination. I found an environment like the one I had in college and graduate school where I feel safe. The scars are healing and it still will take time, but those cracks are healing and I couldn't be more fortunate. Because of all of that, I graduated about a year and a half ago from fellowship at UCSF and decided to stay as faculty as an assistant professor. Some of you know what I've shortened assistant professor to. If you just think about what assistant could be shortened to, just like you know what I've been calling myself on Twitter. Part of my work with others is building a clinic specifically for minoritized youth that involves narrative therapy, healing from discriminatory trauma, teachings and groups for parents around discrimination and mental health, and collaborations with other clinics. We're still building a lot of those modules and wanted to do it very intentionally with community input, but that's where we're going with things. And right now, what we do is teach them about the minority stress theory and also talk about racism and discrimination as we go through their care and do med management too. In honor of the friends, family, mentors, and people I love who saved my life once upon a time, the clinic is named after our group nickname that started in college and graduate school, which was the Muses. Thus, our team has called our clinic that opened July 2023 the Muses Clinic for Minoritized Youth. And I'm excited to see where these new chapters I get to write with all of you take us. So this is with special thanks to Mark Fusunyan. He was my partner when I first did this project. And then Peter, Kathleen, and Alexis, and the Washington Chapter American Academy of Pediatrics for inviting me, and all my mentors, friends, and family, past and present. Okay. That's everything.
Well, thank you so much. That was an incredible presentation. Yeah, just incredible all across the board. So I will be quiet because I know we have some time left. And I just wanted to make sure that people got any questions answered or put any questions in the chat, or you can just unmute yourself and ask Chase a question.
And I know this talk, I will stay over in case people have questions. But I know this talk sometimes elicits quiet from people because they are like, oh, dang, this is my whole life. And it's a lot to process. And just know I'm here as you go through that. And if questions come up later, I've also had other people who they are nervous about asking questions in front of their colleagues around like things that they have gone through or things that they have done maybe to other people. And I want to say there's no shame here. It is okay to ask those questions. And I'm very open again about everything, as you saw from like literally just gave you my whole history. But I know that that can be also hard for people. So it is okay if you do not feel comfortable asking questions right now. You can email me as well.
Yes, they do, Dr. Hoops. Beyonce
That was great.
condition around here.
Hey Chase, this is Mike, and I key him for some picky to Atkins Spokane.
Mike, your you're coming in and out. You might have to like turn off your
Oh no. Okay.
yeah, you might have to turn off your camera and then try that. Oh, there we are. Okay, here.
I just have to get out of my car. Can you hear me okay now?
Yes,
We can
yes.
hear you. Yeah.
Okay. Anyway, I just wanted to thank you, Chase. Super personal talk and super helpful. I really appreciate you sharing your experiences and all the things that you've learned and gained and strategies and things like that. Is super helpful for all of us and inspiring. So thanks. Appreciate it.
Thank
I don't
you.
have a specific question. I've got to process a lot of things before I have questions, like you said. So.
And thank you for saying that. It means a lot to hear.
Dr. Jack. There's just like a lot of love coming through the chat, which is pretty
Yeah,
awesome.
thank you all just for being here. And like, even though it's been years of doing this, I never know how to land. So I just really appreciate all of you being here and showing up today. Oh, also you can all email Peter and Kathleen later. And like, if you have email, like they can share my email with all of you too, is another thing as well.
Absolutely. Absolutely. And so, and I know that we are at time and people have places to be. And so there is some stuff coming through in the chat about sort of joining the webinar. And if you have any feedback on the webinar, I'm sending that through a short survey. And then we will be having our next webinar. You will not see me and Kathleen, but we will be here. You'll have different hosts at that time, September 25th. And so right after school starts for some people. And for those that are taking off, I hope you all have a great morning. And Dr. Anderson will stay on a little bit longer in case there's anybody that wants to ask any direct questions. So thank you.